This is a short review of the PowerPoint presentation titled Multiple Chemical Sensitivity Top 10 Myths, which was presented on International Awareness Day, May 12, 2022. These are the top 10 arguments against the existence of multiple chemical sensitivities as a clinical entity. There is no accepted consensus definition for MCS. MCS doesn't exist. Reacting to structurally unrelated chemicals cannot be explained biologically. Provocation of symptoms from low-dose exposures to common chemicals is not consistent with classical toxicology. MCS can't be understood according to any known pathophysiological mechanisms. MCS patients do not have a hypersensitive sense of smell. Attributing multiple symptoms to low-level chemical exposures is a misperception. On the other hand, the evidence that MCS is a psychiatric condition is strong. Provocation of symptoms from chemical exposures is just a conditioned response. So, MCS patients should be encouraged to increase their exposures to chemicals. What we will quickly review is whether or not these arguments are valid. There are 6 criteria for the diagnosis of MCS. Symptoms are repeatedly reproducible with exposures to chemicals. MCS is a chronic condition. Low levels of exposure that were previously tolerated and tolerated by others results in the manifestation of symptoms. The symptoms improve or resolve when the incitants are removed. The responses occur to multiple chemically unrelated substances, and the symptoms involve multiple organ systems. These 6 criteria were validated by the Environmental Health Research Unit at the University of Toronto in 2001 and remain unrefuted more than 20 years later. These criteria are also commonly used in multiple research studies on MCS. To state that there is no accepted consensus definition for MCS is wrong. Prevalence studies measure how commonly a condition exists. There are multiple studies of MCS performed in North America, Europe, Asia, and Australia, which consistently show similar statistics for prevalence. The impact of MCS on one's quality of life is significant. It appears to be a unique public health problem. To state that MCS does not exist as a distinct entity is wrong. The question is, why does it exist? There are receptors on cells called TRPV1 and TRPA1 receptors. They sense and respond to multiple different triggers, including a multitude of chemicals, especially volatile organic compounds, and they can become sensitized by repeated exposures, meaning that they respond to lower levels of exposures, that they respond more strongly, and for a longer duration. There are multiple studies which have shown that these receptors are sensitized in chemically sensitive patients. To state that reactions to structurally unrelated chemicals is not biologically explicable is just wrong. It is frequently argued that symptom provocation from low-dose exposures to common chemicals is not consistent with classical toxicology. Traditionally, it's been thought that substances are toxic at high doses. However, that 500-year-old paradigm of toxicology has shifted. We now know that there can also be responses to low doses, that there can be more than one dose that causes reactions of different types in different systems in the human body. We also know that in real life, there are always multiple exposures going on at the same time, that you can't just consider one chemical and ignore all the others. This is called systems toxicology, where exposures can cause multiple impacts at the same time on different systems. So the results of toxicology studies might depend on what's being measured. There can be multiple what we call endpoints. It could be cancer, or destruction of tissues, or more subtle changes like oxidative stress, which is damage to cells, or systemic inflammation, which is a wired-up immune system on alert, or changes in cell function. Toxicity can change the function of receptors on cells, including making them hypersensitive. And so it's wrong to state that MCS is not consistent with classical toxicology because the old classical toxicology paradigm has now shifted. MCS is clearly poorly understood by many people. And one argument frequently made is that there are no known pathophysiological mechanisms which could even explain it. However, there are multiple linked pathophysiological mechanisms found in MCS, such as oxidative stress, which is damage to cells from inadequate detoxification, and systemic inflammation, which always occurs with oxidative stress, sensitization of receptors known to respond to chemicals, and abnormal neural processing of odors as shown in brain imaging. MCS is complex. Sensitization in MCS has been demonstrated in the brain and the respiratory system in multiple studies. There are also mechanisms shared with other comorbid disorders. Comorbid disorders are those which occur along with the one you're considering. For example, MCS is frequently comorbid with myalgic encephalomyelitis, chronic fatigue syndrome, asthma, and chronic cough, and chronic pain disorders like fibromyalgia and migraine. These common comorbid conditions share pathophysiological mechanisms with MCS. That MCS cannot be explained by known pathophysiological mechanisms is just a myth. More than 90% of chemically sensitive people claim to have a hypersensitive sense of smell. Yet there are multiple studies which consistently demonstrate that the threshold to detect an odor or to be able to discriminate what that odor is the same in MCS as control groups. So how does one explain this discrepancy? It's explained by something called attention bias, which basically means that if something is perceived as a threat, it is neurologically detected earlier. And what's been shown is that in MCS, there is a faster recognition of odors from low-level background odors and a faster identification via this neurological mechanism. So there is evidence to explain the patient's observations that they can sense olfactory triggers more easily. Therefore, to state that MCS patients do not have a hypersensitive ability to detect threatening odors is also a myth. As I said earlier, MCS shares mechanisms with other comorbid biological conditions. For example, if you also have fibromyalgia and you have a chemical exposure, you can exacerbate the fibromyalgia pain. What we know is that the receptors of TRPA1 and TRPV1, which are sensitized in MCS, exist in multiple organs, not just the brain and the respiratory system. They're involved in chronic pain, and where they are expressed, that is, where they exist on cells in different organ systems, could dictate some of the symptoms experienced due to chemical exposure. And of course, these receptors can become sensitized. So to attribute multiple systems from multiple organ systems to low-level chemical exposures is not a misperception. It is a biological phenomenon that is real. One of the strongest arguments made regarding causation made by MCS deniers is that it is just a psychiatric condition. The evidence used to support this argument are studies called cross-sectional. In other words, they are making observations at a moment in time after the MCS has already developed. What is significant about this is that making comparisons at a single point in time after MCS is developed cannot be used to imply causality, and that is just a statistical epidemiological fact. Being associated, that is, occurring together, is not evidence by itself for causation. In fact, developing MCS has also been found to precede the onset of mental health symptoms, and obviously the cause of a condition cannot occur after the condition has already developed. Furthermore, many MCS patients do not even meet the criteria for a psychiatric diagnosis. In summary, the evidence that MCS is caused by psychiatric illness is actually very weak. It is therefore important to recognize that the reason that the National Institute of Public Health Quebec concluded that MCS is caused by anxiety was that they used very poor scientific methodology which biased their conclusions. There were no MCS experts involved. They failed to consider and review the multiple studies which demonstrate that TRPV1 and TRPA1 receptors normally sense and respond to multiple chemicals, or that these receptors can become sensitized. They ignored the multitude of studies that these receptors are sensitized in MCS patients. They failed to recognize that functional brain scan studies on MCS patients use known stimulants of these receptors to induce brain changes, which they therefore misinterpreted and wrongly concluded that the changes were just due to anxiety. In contrast, Alberta Health published a review of the literature using better methodology, including involving recognized experts, and they concluded that the weight of evidence substantiates olfactory dysfunction, neurological sensitization, and neurogenic inflammation. There are multiple published papers which try to explain the provocation of symptoms from chemical exposures as a conditioned response, like Pavlov's dogs. However, they're based on studies showing that the stress response in the brain can be conditioned to respond to specific odors. All these studies were conducted using healthy young adults, but there are no studies published on MCS patients actually demonstrating a conditioned response. Nevertheless, these authors then conclude that a potential treatment for MCS is deconditioning, repeatedly exposing MCS patients to chemicals while using biofeedback or a relaxation therapy. So far, there is one paper published approximately 20 years ago which reviewed just 3 cases, 2 of which were not followed for long-term observation. MCS patients should not be encouraged to increase their chemical exposures. There is no significant evidence that this is effective, and there's no evidence that it's safe. In fact, studies performed 5 years and even 10 years after the diagnosis showed no evidence for any reduction in TRPV1 receptor sensitivity. MCS patients should not be encouraged to increase their chemical exposures. In fact, since sensitization occurs from repeated exposure, it is logically more likely that it would exacerbate the condition. So there you have it, the top 10 facts of an MCS. It exists. There's a consensus definition. Reactions to structurally unrelated chemicals is biologically explicable. Provocation of symptoms from low-dose exposures to common chemicals is consistent with modern toxicology. And MCS can be explained by known pathophysiological mechanisms. MCS patients can detect odors more quickly than other people. Attributing multiple symptoms to low-level chemical exposures is valid. Evidence for psychiatric causation in MCS is weak. Decreasing chemical exposures is the best management strategy, and MCS patients have a valid medical disability with the legal right to accommodation.